Please, again, everyone, show me that your name is Dr. Khalid Suwaiti. Please, you can change your name. You can edit your name from the Zoom. Just rename, but you can press on the name and rename, and you can write your actual name, because all it show me that you're Dr. Suwaiti.
So please, Naba, can we start?
Please, everyone. Yes, we can start. But just, Doctor, I want to tell something. Everyone show me that their name is Dr. Khalid Suwaiti. If everyone can just please rename themselves and enter their actual name, please.
So please, before we start, just enter your actual name and just be sure that your Zoom is muted, so will not interfere with presentation. After we finish, we can unmute. Okay, so we're going to talk about the high-risk pulmonary embolism and how PERT team can make difference, and really should we implement that kind of strategy in all hospitals all over the world or not. So PERT team, we started to create strategies and policies in 2020, but unfortunately we were not able to apply in our hospital because of the COVID-19 time was very busy actually, and there's no time to really to implement or to share any knowledge with anybody during that time. So tell me what you're going to do. If you are having patient with refractory obstructive shock, massive pulmonary embolism, not responding to systemic thrombolysis, high dose of vasopressors, refractory or super refractory pulmonary embolism has been diagnosed. You don't have really much to do in these case scenarios because mortalities are very high. Actually, it's ranging from 50% upward. So it's a very challenging case, nothing in life to be feared, only to be understood. And now is the time to understand more so we can fear less and we can really think outside the box. Extraordinary problem has to be solved by extraordinary solution. When you are dealing with really high-risk PE, is an extraordinary problem, and then you need to find extraordinary solution, not a regular solution. Let us see this video about how the pulmonary embolism is spreading. The thrombus will be formed beyond the valve of the vein. And then we'll go all through with the pulmonary circulation. So if your patient is unlucky, it will obstruct one of the main pulmonary arteries and will cause a catastrophe. So high-risk pulmonary embolism is actually killing. 3 months mortality about 15% in all BE, and in massive BE is reaching 50%. Latest US report showing annual deaths of 200,000 as a primary cause of death from pulmonary embolism, more than combined HIV, RTA, and breast cancer deaths. So BE cause more deaths than combined all of them. Equal to one jump jet crash per day. So if you have a jet crash jump per day, it is actually equal to pulmonary embolism deaths. And roughly it causes 10% of hospital deaths in general. And BN mortality remains high, up to 40 to 60%, despite all what we are doing. And 1 out of 10 patients die in hospital because of pulmonary embolism, which is actually a huge number, and we have to do something for that. Is it a worldwide problem? Yes, it is a worldwide problem. It's not only a problem of the Gulf area, but it's a worldwide problem. And prevalence is very high. BE is the most common preventable cause of death in the hospital, and VTE prevention is #1 priority to improve safety in the hospitals. And actually is a trend or one of the KPIs in the quality improvement tools. Any quality improvement tools, the VTE prevention is #1. So that's why we thought about creation of PERT team, composed of expert team to take care of our pulmonary embolism patients. So when you have a high risk of PE, PERT team will be activated. It's composed of intensivist, intervention cardiologist, pulmonologist, and PE nurse. So what PERT team is going to do, the primary nurse to be called initially by nurse activation when you are dealing with recent diagnosis of pulmonary embolism. And PERT team activation will be only in case of high-risk pulmonary embolism. If the PE nurse evaluated the patient and identified that patient is high-risk PE, so she is going to activate the PERT team. The PERT team will come to decide where the patient will go. Is actually going to ICU, to the ward, what anticoagulant will be started as systemic or versus catheter-directed thrombolysis will be initiated. And then the team dynamics will continue to follow up and refer patient to further specialty like hematologist, for example, or intervention radiologist. The guidelines, before really to go to discuss the topic, I'd like to review the guidelines, latest guidelines with you to understand really what we are going to have. The ACCB guidelines, the latest 2016, the American Society of Hematology venous thromboembolism guidelines 2018, American Society of Hematology Anticoagulant Therapy 2018, and the first Australian venous thromboembolism guidelines end of 2019. So what we need from the front line? The front line is supposed to be the ER team. So the ER team will assess the patient, will use the clinical probability score, and if the clinical probability is intermediate or high, they are going to order CT scan, and if CT scan confirmed pulmonary embolism, will further assess the severity index by PE nurse and activation of PERT team for high-risk pulmonary embolism. So how to diagnose pulmonary embolism? We have a D-dimer, of course, on board. A negative D-dimer can roll out PE in low probability cases and will ignore it in high probability cases. Clinical probability, we have plenty, but we are using a revised Geneva score. lower limb venous ultrasound, easy bedside, positive D-dimer. In case of positive D-dimer, we have to have positive D-dimer before going to lower limb venous Doppler. So this is a revised Geneva score, and this is a symbol composed of 11 criteria, and will they categorize patient into 3 categories: low probability, intermediate probability, or high probability, based 0 to 3, 4 to 10, or more than 10. Patient with intermediate and high will go to have a CT scan, and you will see clearly that there is this is a pulmonary, main pulmonary, right and left pulmonary artery. You will have a filling defect significantly here, saddle-shaped embolus encroaching on both right and left pulmonary artery. We don't like to see this actually, because it's going with have massive pulmonary embolism. And this is a normal pulmonary circulation. You don't have any filling defects there. So what is the alternative imaging option? So if the patient is having contraindication for CT contrast or spiral CT scan, we have a VQ scan, which is ideal for at-risk non-pregnant patient at risk of acute kidney injury. We'll go for VQ scan, but try to avoid in pregnant lady. The VQ scan is contraindicated. A lot of people doesn't know about it. MRI with DTI, or direct thrombus imaging, best in pregnant lady. So if you have a pregnant lady and you need to do imaging study, better to go for MRI. Conventional angiography is a gold standard, but carry high mortality. Transthoracic echocardiography, only in 30–40% of BE have a positive finding. You don't expect that all patients they have finding in transthoracic echo. Echo is good, just you might see a paradoxical septal wall motion abnormality, elevated pulmonary artery pressure. Sometimes clot can be seen in RA, RV, or right pulmonary artery. In case of submassive VE, as you can see clearly, RV strain with dilated RV and hypokinetic RV. Massive pulmonary embolism indicated to have an echo if the patient is unstable. So you don't have time to shift patient to CT scan to diagnose. If the diagnosis is conclusive by echo, will be fine to initiate therapy. BE nurse is the first responder. Once the diagnosis will be established, the ER physician will activate and call the PE nurse, and the BE nurse will do what's called BSI score, or pulmonary embolism severity index. It's composed of this 1, 2, 3, 4, 5, 6 criteria, and a risk factor will be either low or high. If you have only one criteria, like patient age, or have chronic pulmonary vascular disease or cancer, or pulse rate is high, more than 110, or systolic less than 100 but more than 90, or SAT less than 90, you diagnose a severe pulmonary embolism. So what is the management based on BE severity index? Low risk, you will admit to general ward, and high risk, you will have an ICU admission. Better to have an ICU, or at least high dependency unit admission. Anticoagulant therapy to start for all, unless contraindicated. So management, anticoagulant for all, and then you decide, should we go for local thrombolysis or systemic thrombolysis, or that's it, anticoagulants enough, or some of the patients will go for mechanical intervention, and some of the patients will go for IVC filter or embolectomy. So PERT team should be an expert team to differentiate also between the massive and submassive pulmonary embolism. And massive BE, we know that we have a high hemodynamic compromise, and submassive BE will further categorize to higher risk submassive BE by using what's called BOVA score to be more than 4. We know that massive BE will go for systemic thrombolysis, and submassive will benefit more from catheter-directed thrombolysis. They try to do systemic thrombolysis for patients with high-risk submassive BE, and they found significant hemodynamic improvement, but actually the incidence of high-risk bleeding or severe bleeding is high, and the incidence of intracranial bleeding is high. Thrombolytic therapy in BE, persistent hypotension or shock for 15 minutes. So if you have a patient remained shocked for 15 minutes due to pulmonary embolism, considered to is a massive BE, and he actually needs to be thrombolized. The dose 100 milligram over 2 hours, and the evidence of recommendation to grade 1B in European Society of Cardiology guidelines, SCB is a grade 2B. Greatest benefit to be given within 48 hours, but still of symptoms, but still we can give up to 14 days. This is a protocol has been done by Australian people. Actually give IV heparin bolus 5,000 when you have massive BE with systemic thrombolysis. Alteplase 10 milligram bolus, then followed by Alteplase 90 milligram over 2 hours to complete the 100 milligram, and heparin infusion should be continued. Some people are very conservative, and you give heparin only after the TVA and after reduction of the ABTT. So bleeding risk in this protocol 6% versus 3% of anticoagulation, regular anticoagulation. Thrombolytic therapy in pulmonary embolism, improve pulmonary artery pressure. Actually, AV oxygenation improved, pulmonary perfusion improved, reduce recurrence, which is very, very important here. So thromboembolic pulmonary hypertension will be reduced if you give thrombolytic therapy. Reduce mortality in massive BE, but not in submassive BE, and check, because you know the patient who improved in thrombolytic therapy in submassive BE died because of the intracranial bleed. So the incidence of mortality remains the same. It checks the BE severity index and risk stratification for bleeding. We need to really assess bleeding risk before considering to give thrombolytic therapy. BOVA score, if you want to know about it, you have also heart rate more than 110. You have systolic pressure less than 100, but more than 90, because if less than 90 means that's massive BE. Elevated cardiac trope I and RV dysfunction based on TTE, transthoracic echo, or CT scan. And CT scan really can tell you exactly the RV to LV ratio more than 0.9. And we usually ask the radiologist and or sometimes radiologists write by themselves that RV is dilated more than 0.9 versus LV. So if low score 0, if 1 or more, it is high, but it's very high score, which benefit in the studies from catheter-directed thrombolysis is more than 4. So BOVA score more than 4 is a high risk submassive BE and really deserve attention here. So what to do if you have systemic thrombolysis is contraindicated. So contraindications for systemic thrombolysis, you have either mechanical intervention, which is not available in most of the center, or you use catheter-directed thrombolysis, which is available in our center. And mechanical intervention is the most invasive therapy, will carry very high risk of mortality, 20% versus 50% if untreated. Patients who receive systemic thrombolysis remain hypotensive and shock should go also to catheter-directed thrombolysis. So we have catheter embolectomy fragmentation as a kind of mechanical intervention. We have surgical embolectomy as well by surgeon, cardiac surgeon. And all this patient will have massive BE with contraindication to thrombolysis. So systemic versus local thrombolysis is an area of debate, and some of the centers now, especially in Turkey, they are actually going to have this catheter-directed thrombolysis from the start, even if systemic thrombolysis is indicated, because they start to be very expert about the procedure. What are the choice of anticoagulant drugs? So we have a parenteral anticoagulation, we have a NOACs, we have Warfarin, we have a lot. So the guidelines from ACCB guidelines said clearly that parenteral anticoagulation versus NOACs, you have to consider the patient if have potential for decompensation at any time or not. You might need a thrombolytic therapy in the near future or not. Is going to have invasive intervention or not. Availability of reversal agent in your center is present or not. And then you choose between NOACs and parenteral anticoagulation. Non-pregnant, non-cancer patient, NOACs can be given, or Warfarin, and cancer patient, they'll get benefit from low molecular weight heparin. Also pregnant lady and lactating lady will benefit from low molecular weight heparin rather than NOACs or Warfarin. So when to consider outpatient management, very low risk PE patients can give an outpatient treatment or at least admit 1 or 2 days in the hospital and consider early discharge and go home. Therapeutic unfractionated heparin dose, we know clearly 80 units per kg, followed by 18 units per kg per hour. Cardiac and stroke 70, followed by 15 units per hour per kg per hour. Fixed dose sometimes be given at average 5,000 IV stats in 1,000 per hour. But you have to understand that the unfractionated heparin having unpredictable anticoagulation, 10 times the risk of head compared with low molecular weight heparin. And the beauty of using it is fully reversible with protamine sulfate. Regarding the low molecular weight heparin, like enoxaparin, like weight-adjusted dose, 1 milligram per kg of actual body weight, BID, creatinine clearance less than 30, you reduce the dose to half, 1 milligram per kg per day. The best evidence in cancer patient and pregnant lady as well. Predictable anticoagulation from the dose you are given per kg. They have an ease administration than heparin, and using ABTT all the time. It has 10 times less risk of head compared with unfractionated heparin, and partially reversible with protamine sulfate. So a lot of people also doesn't know that protamine sulfate can reverse up to 60 to 80% of the enoxaparin dose. You monitor with anti-factor 10A assay in obese, renal failure, and pregnant lady 4 to 6 hours after the dose. So you do level as a peak level 4 to 6 hours after the dose, and check. In prophylaxis, we need to be between 0.2 to 0.5. In therapeutic, we need to be 0.6 to 1.2. The new American Society guidelines, they mention clearly maybe you don't need to monitor anti-factor 10A in obese patient, and you go with actual body weight, which has been criticized by other guidelines. So still, we are believing that patient obese, especially body mass index more than 40, plus patient who is acute having kidney injury or renal failure or pregnant, you need to check the anti-factor 10A level. So debate will continue, which is the best to be used, unfractionated versus low molecular heparin, and this debate will continue for a decade. But American Society Guidelines 2018, they mention clearly in critically ill patients, the panel suggests using low molecular weight heparin over unfractionated heparin based on the PROTECT study. So how to reverse protamine sulfate? You give 1 milligram per 100 units heparin given in the previous 3 hours, or enoxaparin 1 milligram per 1 milligram enoxaparin in the previous 8 hours, and you don't exceed 50 milligrams. So you give 15 or 12.5 to 15 milligram IV. And you have a full reversal of unfractionated heparin and 60 to 80% reversal of low molecular heparin, and no reversal of fondaparinux. Also, you might repeat the protamine sulfate at half dose, like 0.5 milligram per indicated amount if bleeding continued. What's the updates about vitamin K antagonist, the Warfarin? Actually, the new guidelines, American Society of Hematology, recommend to give 10 milligram daily for 2 days. And then you check an INR, and you need to have an INR between 2 to 3, and all kind of patients, including antiphospholipid antibody syndrome. Previously, they are going to have to give a higher dose or higher INR for antiphospholipid antibody syndrome, but need to continue between 2 to 3. Maybe this patient will benefit towards 3 rather than toward 2. Avoid non-steroidal anti-inflammatory, antiplatelet, and certain antibiotics because drug-drug interactions, and discontinuation abrupt rather than gradual. I see a lot of cardiologists like, oh, we now warfarin is 5 milligram, we need to stop, so go to 3 and then 2. No, you don't do that. Don't do that. Preoperative bridging of vitamin K antagonist to stop warfarin 5 days pre-op. This is the usual strategy we are doing. We'll stop warfarin, we'll administer therapeutic enoxaparin, bridging pre-op and post-op. This is also has been recommended by the American Society of Chest Physician. But actually, the American Society of Hematology, latest guideline 2018, they said, no, you don't need to bridge. Just you need to stop 5 days warfarin, and then patient go to the surgery after 5 days. If you patient on enoxaparin already, last pre-op dose should be 24 hours before surgery, and you to resume 48 hours to 72 hours after high-risk bleeding surgery. We are talking about therapeutic anticoagulation, not prophylaxis. Prophylaxis you can start, of course, 6 hours after low-risk bleeding surgery and 12 hours after high-risk bleeding surgery. Okay, but remember that therapeutic is starting at least 48 hours after the high-risk bleeding surgery. NOACs, we have a rivaroxaban, 50 milligram 12 hours for 3 weeks, and then 20 milligram once a day. We have the abexaban, 10 milligram BID for 7 days, then 5 mg BID later on. And we have indoxaban, 30 milligram once a day. And we have also a dabigatran. All of them actually are anti-factor 10A, except dabigatran, which is direct thrombin inhibitor. So all are affecting the INR and thrombin time and not the ABTT, except the dabigatran, but no need to monitor, actually, because this is a target-specific anticoagulant. So you don't need really to monitor the anticoagulation effect. Could NOACs be given in massive BE or pregnancy? No. Could NOACs, no evidence. Could NOACs given with creatinine greater than 15? No, no evidence. Could NOACs given along with the cytochrome B 450 inducers or inhibitors? No evidence. What about the subsegmental BE? If a lot of CT scan reported subsegmental pulmonary embolism. So what you're going to do? I have seen catastrophe because of that. Actually, many patients with subsegmental BE, and they have subdural or just evacuated subdural, or they have melena a couple of weeks back, and you start anticoagulation, they bled up to death. So actually, the guidelines is clear here. ACCB, American Society of Hematology, they clearly mention if the patient doesn't have proximal pulmonary embolism or DVT, no need to treat. We treat only if you have a DVT. Or patient have a low pulmonary reserve, like thromboembolic pulmonary hypertension, for example, with marked respiratory symptoms, you can start anticoagulation. But otherwise, you don't need to start if that's just simple subsegmental BE and no pulmonary issues, and you don't need to start. How long to treat VTE with anticoagulant? If you have a proximal DVT BE, just 3 months is enough. If you have the BE is explained by provocation of surgery of trauma. If like provocated or provoked by non-surgical risk, like patient has prolonged travel or like that, so you need to extend to 6 months, 3 to 6 months. If you have a distal DVT, you don't need to extend more than 6 weeks. That's more than enough. And if you have unprovoked VTE, recurrent VTE provoked by cancer or antiphospholipid antibody syndrome, here you need to have a long-term treatment, lifelong treatment. Special situation. What you have to do in a special situation. PE in pregnancy. Of course, low molecular weight heparin is the anticoagulant of choice based on strong evidence. Systemic thrombolysis in massive BE with low bleeding risk. You can give alteplase in pregnant lady with massive pulmonary embolism with low bleeding risk. Catheter-directed thrombolysis or mechanical intervention in massive BE or submassive BE with high bleeding risk, like peripartum period. This is the highest bleeding risk in the peripartum period. IVC filter if the BE within 1 month of expected delivery. UK guidelines advise against vitamin K antagonist. Some people are giving vitamin K antagonist in the middle trimester, and no, but actually the NICE guidelines recommend totally against using vitamin K antagonist during pregnancy. Thrombolysis during pre-arrest or arrest condition. If the BE is suspected clinically in acute decompensated patient, you give thrombolytic therapy. Transthoracic echo detect acute right heart strain, actually in pre-arrest condition. Cardiac arrest with suspected BE, thrombolysis increase the incidence of ROSC. And British Society guidelines, Thoracic Society guidelines suggested alteplase 50 milligram IV bolus in both pre-arrest and arrest condition. You can give half dose if you treat blindly. Recent study revealed that thrombolysis during unknown out-of-hospital cardiac arrest will not benefit the patient. So when actually a BTS recommend to give 50 milligram IV bolus in the pre-arrest condition, also some of the centers encouraged to give en route to the hospital during the ambulance time. Any patient with cardiac arrest with suspected pulmonary embolism or MI, they give immediately 50 milligram pre-hospital, and they found no benefit. Regarding the super refractory BE, actually, when we in ESCM 2019, we attended a webinar about VA ECMO and super refractory BE because the scientist was there conducting a study and revealing the result of the study. VA outcome now is a first-time device in auto-refractory cardiogenic shock, and guidelines clearly mention that consider VA ECMO if the patient in refractory or super refractory pulmonary embolism. So you give thrombolytic therapy, no benefit. Catheter-directed thrombolysis, no benefit. You might consider, or you have to consider actually VA ECMO, otherwise the patient will not survive. What about COVID-19? So actually in COVID-19, the meta-analysis of studies in hospitalized patients with COVID-19 found overall VTE incidence 14.1%, which is not really much different from other categories of severely ill patients. And if you look about ICU patient, usually you have 5 to 16% incidence of VTE prophylaxis. And also septic patients, there's a new study revealed the incidence reached to 30%. Actually, during the start of the COVID-19, and we have single center study, it's called the VEDEX trial, has been done by Jean-Louis Vincent and his group, revealed that 30% of patients with COVID, they have a pulmonary VTE, they have a DVT or B at the time. And they used the imaging study in his trial, but it was a single center trial. But when they investigated more, they did not find really much higher incidence of COVID-19 VTE than other septic patients. So initially we start to use therapeutic anticoagulation for all patients based on the VEDEX trial. But lately we have ATTACK or ATTACC, which run 3 randomized controlled trial, evaluated the role of therapeutic anticoagulation in COVID-19 pneumonia, terminated early because of the futility and high risk of bleeding. They did not find any improvement in the VF ratio and did not find any improvement in the mortality, but they found significant increase in the risk of bleeding. And we have a guidelines has been published 12 days ago, February 11, 2020, from National Institute of Health, US, to summarize the anticoagulation guidelines in COVID-19. They mention clearly that no evidence for routine testing of coagulation cascade or VTE screening. You don't need to have regularly coagulation studies for COVID-19 pneumonia. You do it if you suspect pulmonary embolism or DVT. Patient on antithrombotic or aspirin should continue, and a patient came with dabigatran or came with enoxaparin with Blavix, and continue the same. Don't stop. No evidence of using higher doses of VTE prophylaxis. So some of the center also were using, even our center using like 40 milligram BID enoxaparin or something like that. The guidelines is recommending against using higher dose. So use as if other patient in ICU. If the patient is regular weight, use 40 milligram once a day. If the patient is body mass index more than 40, like same like other guidelines mentioned, SCP guidelines, use 40 milligram BID, and if the patient is having renal impairment, creatinine less than 30, you can use 30 milligram once a day. Less than 15, you don't have evidence to use low molecular weight, use sub-Q heparin 5000 BID. No evidence of using extended VTE prophylaxis on patient discharge. Also, we have seen plenty of patients using VTE prophylaxis at home, even without admitted to the hospital. This is totally contraindicated. There is no any rationale of using VTE prophylaxis at home, or to start VTE prophylaxis in the hospital and then continue at home, unless we have the FDA recommendation when to have extended DVT prophylaxis, like post-surgery, like orthopedic surgery, like that. Otherwise, no need. Regarding the therapeutic anticoagulation may be considered in rapidly deteriorating patient with possibly VT. So if you want to consider therapeutic anticoagulation in COVID-19 pneumonia, you have to have a patient with rapid decompensation from pulmonary and cardiovascular parameter, and there is no other explanation, and there is no evidence of really secondary bacterial infection or cytokine storm or something like that. And you think about BE, so here you might start therapeutic dose and then investigate for like spiral CT or so. Also, low molecular weight heparin is first-line therapy, and they recommend against using NOACs in prophylaxis for this patient because we don't have evidence, and we have all the evidence in the last year and year and a half is going with low molecular weight heparin, and then you go for unfractionated second. No evidence for DVT screening in COVID-19 patients. Don't do routine screening for DVT in patients with COVID-19 unless there is really signs of DVT or DVT is suspected. Take-home message: VTE is common, costly, tragic, preventable. Risk assessment model needed, definitely, and the clinical pathway is crucial when you manage this kind of patient. VTE prevention is #1 priority to improve safety in hospitals. Size of BE does not correlate with the severity is also an important issue. And this is a pathway we created, the BE clinical pathway. You do stat ECG, TROP-I, ProBNP, D-dimer, and then if the PE is suspected based on the revised Geneva score, at that time you either have low clinical probability, do D-dimer. If negative, thank you very much, be excluded. If the patient has intermediate or high risk probability, here you need to have a CT pulmonary angio. You consider other diagnosis, or you consider BE, or you consider no BE. Also, always consider to have a lower limb Doppler. If the B confirmed, here you need to have a simplified pulmonary embolism severity index to be done by BE nurse. So here BE nurse has to be activated. And if the patient low risk, which is 0, admit to the general ward and start anticoagulant and go home if it's stable. If the patient high risk, 1 or more, hemodynamic compromise present or not, yes, so we go systemic thrombolysis, no, we'll go for BUVA score. If 4 or more, go for catheter-directed thrombolysis, no, you will go with therapeutic anticoagulation. Here, actually, is the time to activate the PERT team when you have a high risk pulmonary embolism based on simplified pulmonary embolism severity index. Okay. If super refractory pulmonary embolism, which is not responding to systemic thrombolysis, the patient should go for VA ECMO. So PERT is not an option; it has to be done, and the PERT has been standardized all over the world. And I don't know why in Gulf area we don't have this kind of strategies, but still we have a very high mortality from pulmonary embolism. Again, the words of Einstein: you have to learn the role of the game, and then you have to play it better than anyone else. So I believe the more we are going to learn, the more we can change the future. Thank you very much. I appreciate it. Thanks, Sanu. Thank you very much. Thanks, Nala.
Thank you, doctor. Thank you so much. Thank you. If anyone have a question, and Doctor, you can see the Q&A box if there is any question. Dr. Shaya have a question. You can answer.
Oh, I can see. Let me.
There is a question from Dr. Shaya and from Dr. Osama.
You can read it because I cannot see it. You can read it, Nava. Oh, here I can see the question.
Okay.
Oh, yes.
You can see now.
From Dr. Shaya.
Yes.
Protein low effect is better than acid for PE prophylaxis, not for treatment, according to the PROTECT trial. Yes, I agree about that. Actually, based on PROTECT trial, which is compared unfractionated heparin versus low molecular weight heparin, they found low molecular weight heparin is better in critically ill patients. You are correct, but again, most of the centers, they recommend to use low molecular weight heparin based on the ease of administration and predictable response. And in COVID, they recommend by name low molecular weight heparin. Regarding Dr. Osama, anticoagulant in COVID patient may need still studies. Yes, I agree, Dr. Osama. Initially, we give all patients very high dose therapeutic anticoagulation, and then we start to calm down and to reduce the dose to 40 milligram BID. And then now the guidelines coming from NIH, US, and coming also from Saudi Arabia here recommend against giving anticoagulation therapeutic or even higher dose prophylaxis in COVID-19 patients. We don't know what is the future, but we have this 3 randomized controlled trial revealing that the incidence of mortality is high. The only positive trial is coming from verdicts from Jean-Louis Vincent when they give anticoagulation and able to increase the BF ratio. This is the only study which was positive. So I don't know what the future will tell. Any other questions?
There is any question, please. You can write on the question box. And Doctor, you can, everyone write their name in the chat box to I know that it is because some of you, their name is Dr. Khalid because I think when you enter, do not change the name.
Yeah, I can see one comment about 4 or 5 case scenarios illustrating this concept would be great. Yes, you are right. We need to really start work on it. So I hope that by the end of 2021, we have more than 5 or 6 case scenarios.
Anyone have a question? Yes, you can ask the doctor. Thank you so much, Doctor. I think I think no one have a question. Thank you so much for the helpful presentation today, and inshallah we will have other presentation with you inshallah next time.
Thank you very much. Appreciate Sanofi really for conducting such good activities. Thank you very much.
Thank you so much. Thank you. See you next time, inshallah, Doctor.
Bye-bye.
Bye-bye.